Chairman, ladies and gentlemen, I have no financial disclosures, and I would like to present you macular holes in diabetic patients. We collected 23 eyes of 21 patients, 15 eyes without retinopathy, 4 eyes with background retinopathy, and 4 eyes with proliferative diabetic retinopathy. And here you see an example of proliferative diabetic retinopathy macular hole. You see vitreous still attached, but you see huge maximum diameter. And it was statistically significant that in these cases, maximum macular hole diameter was larger. And once again, you see after vitrectomy with temporary inverted flap, you see prolonged persistence of subretinal fluid, even if macular hole is closed. So what we found that all macular holes were successfully closed after first surgery, but both minimal and maximum size of macular hole correlated with visual acuity 1 year after surgery. And of course, what is probably logic, we found the best functional results in case of no diabetic retinopathy, a little bit worse in background retinopathy, and worse in proliferative diabetic retinopathy. Here you see again a case of proliferative diabetic retinopathy. Again, you see huge diameter of macular hole on the base and the same persistence of fluid postoperatively. And here is another specific case. This was a somehow usual diabetic traction retinal detachment. After 3 months after surgery, I removed silicone oil. Nothing suggested any problems in OCT, and already 1 week after silicone oil removal, I found a large macular hole. ILM is already peeled by myself, and in this specific case, I peeled a piece of ILM at the vascular arcade, and actually, first of all, I wanted to perform pedicle flap to close this macular hole, but this pedicle flap was very unstable, so I decided to introduce the ILM into the macular hole, and this case is currently stable after 6 months after silicone oil removal, and macular hole is closed. So my conclusion is that inverted ILM flap technique may be successfully used for macular hole in diabetic patients, but this large maximum diameter of macular hole, long-term persistence of subretinal fluid postoperatively may suggest insufficient nutrition in case of proliferative diabetic retinopathy and macular hole, and probably we should rename this disease as macular hole retinal detachment in proliferative diabetic retinopathy. Thank you very much for your attention.
Thank you, Jerzy. Comments, Sangul?
I have a comment on that. Actually, for such eyes, Jerzy, it is like tractional retinal detachment. So you have a very viscous fluid under tractional retinal detachment, and they usually resorb in a long time. So macular holes are similar to that, maybe, probably in diabetic eyes. So the subretinal fluid, subfoveal fluid is a bit more viscous and maybe for long duration, so that they don't resorb quickly. In such cases, Dr. Levent Karabaş, who is a friend of mine in Turkey, has described the suction of the fluid within the hole with 39 gauge needle under PFCL, so that you can get an easier and earlier resorption of this fluid. What do you think about this?
I don't know. Actually, I did not expect to have fluid for so long. Maybe you are right that this fluid is probably more viscous. But usually in macular hole cases, I do not give anything, and I am quite happy with inverted flap and gas. So I did it the same in these cases, despite these cases with proliferative diabetic retinopathy, I used silicone, not just air. I didn't expect. It was for me somehow new finding. Maybe you are right. It is more viscous. My feeling was that it is lack of nutrition. We must look on more cases probably.
One more question. Do you think I don't know, but I'm thinking these very severe PDRs, we know that cytokines have usually a high level. Have you considered that this long-standing subretinal fluid could be related with some kind of chronic inflammation, perhaps?
I don't know.
Okay. We have a question from the audience.
Dear Jerzy, nobody can deny that you are the father of the inverted flap technique in macular hole. But some macular holes are connected with epimacular membrane. And when we peel the epiretinal membrane of the macula, the ILM is peeled together with this epimacular membrane. How do you treat this situation if you have macular hole plus epimacular membrane? Do you make the flap from both the membranes together, or simply you try to find the flap elsewhere?
I try, of course, first, you mean proliferative diabetic retinopathy?
I'm not talking about diabetic retinopathy now, just the case macular hole and epimacular membrane like Packer.
If you have both Packer and epiretinal membrane, I peel epiretinal membrane first and try to avoid peeling of ILM altogether. But you see, you must distinguish two groups. The second group is probably more frequent when you supposed to have epiretinal membrane because of lack of staining, but you do not see real epiretinal membrane on the surface of the retina. And in these cases, I just invert ILM and do not care about epiretinal membrane. Put together both layers.